Today we are going to discuss very short history of diabetes. In spite of that, patient has a very high H1C. We will discuss the case. The case is patient is AB. He is 58 years old with patient history of type 2 diabetes since last 4 years. He is obese, hypertensive, hyperlipidemia, and case of OSA. On physical examination, patient is obese, his BMI is 32, BP is 135/82, and heart rate is 60 beats per minute. Lab shows H1C is high to the tune of 8.3. eGFR is reduced, this is 70 ml per minute. LDL cholesterol is 69. HDL is low, it is 35 milligram per deciliter. Triglyceride is high, it is 250 milligram per deciliter. And liver enzyme AST, ALT is 7200, that is also on a higher side. This obese diabetic patient of age of 58 years is hyperlipidemic, hypertensive. He is receiving the treatment metformin 100,000 milligram BID, lisinopril 40 milligram OD, metoprolol 100 milligram OD, atorvastatin 40 milligram OD, and aspirin 81 milligram OD. Patient profile is he has a very short duration of type 2 diabetes. He is a young person and has no major comorbidities with no major complications that would reduce his lifespan. He is at low risk for hypoglycemia. He would benefit from a more stringent goal. However, he is also obese, hypertensive, hyperlipidemic with obstructive sleep apnea disorder. You see, our American Diabetic Association recommends that HbA1c less than 7 is a reasonable goal for most non-pregnant adults and Asian people. In addition to efficacy, following consideration predominate in determining pharmacotherapy for him, such as risk of hypoglycemia, weight loss, minimize weight gain, reduced risk of heart failure, ASCVD, CKD, and cost of therapy. You see, the ideal H1C which one should achieve is 5.6 to 6.4, but we are slightly lenient in this case because he's an obese person, his age is 58, his BMI is high. So we want to keep a goal of H1C less than 7. This patient is willing to start another medications but is concerned because he sometimes forget to take his pills and fears that additional pills will only make this worse. He is scared of taking multiple pills. He doesn't want to have injectable therapy in the form of insulin. In this case, fixed-dose combination pills may improve patient adherence by once daily dosing, less complex treatment regimes, fewer pills, improved side effect profiles, and adherence. So friends, people with type 2 diabetic patient commonly live with multiple comorbidities among with hypertension and cardiovascular diseases are the most common. Monotherapy cannot address these multiple defects and often lead to failure to maintain glycemic control over time. Current diabetes guidelines encourage early adoption of oral combination therapies while simultaneously emphasizing the importance of individualized treatment. ADA recommendation is in appropriate high-risk individuals with established type 2 diabetes, the decision is to treat with a GLP-1 agonist or SGLT2 inhibitors to reduce major adverse cardiac events, hospitalization, heart failure, CV death, or CKD progression should be considered independently of baseline H1C or individualized H1C target. Luckily, we have got a very important combination of empagliflozin and linagliptin, which is available as first-line class treatment in SGLT2 and DPP4 combination group of disease. Now, what is SGLT2? SGLT2 is a class of novel oral glucose-lowering agents that mediates glucose lowering action by increasing urinary glucose excretion in the proximal tubule of the kidney. The salutary effect of its ability to act independent of insulin secretion and action and render it suitable to administer disease course. They exert its glucose lowering effect by elevation of incretin hormones that are GLP and GIP, which are secreted in the intestinal. DPP-4 inhibitors, they inhibit the DPP-4 receptors. That's by they prevent the degradation of GIP and GLP in the intestine. This increased GLP and GIP is responsible for increased secretion of insulin and decreased secretion of glucose. Combinations of these agents have potential to show the additive glycemic control due to their complementary effect. Empagliflozin cardiovascular outcome event trial in type 2 diabetic patient, that is EMPA-REC outcome trial. This report reported that 3P MACE outcome occurred in a significantly lower percentage of cases in empagliflozin compared to top of standard care. In addition, CV safety of linagliptin DPP-4 inhibitors was further evaluated in Carmelina and Carolina trial. So, HbA1c determined by EMPA-LINA combination has demonstrated a HbA1c reduction of the tune of 1.81 when the baseline insulin HbA1c level is more than 8.5 at the end of 24 weeks in metformin treated groups. That means if you pay HbA1c is 8.5 and patient is receiving metformin and you add this FDC of EMPA-LINA 525 combination, there is a significant decrease in HbA1c of 1.81. The benefit on glycemic control were maintained at week 52 is a long-standing control, and then a higher percentage of patient achieves HbA1c less than 7 with this combination. The combination offers a suitable component in a strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain with improvement in overall lipid profile. A reduction in the incidence of genital infection associated with the SGLT2 has been reported when a DPP-4 inhibitor is added with SGLT2. The reason behind this is perhaps when we use SGLT2 and DPP-4 combinedly, there is a better control of blood sugar, and this better control of blood sugar causes less chances of genital infection due to SGLT2. So, in summary, EMPA-LINA combination that provides robust HbA1c reduction and 2 to 4 times higher order of patient reaching the goal HbA1c compared to individualized agent with low hypoglycemic risk. So, friends, at the end, I should say, if a patient is on metformin and is not adequately controlled, you should give him a SGLT2 and DPP-4 inhibitor combination. And this SGLT2 and DPP-4 inhibitor combination has a synergistic action. And the most important thing, there's a very low risk of hypoglycemia or any other major side effect with this combination, and the glycemia will be better controlled. So this is a take-home message. Thank you very much for your kind listening.